This is Dr. Lauren Mell, University of California, San Diego, Department of Radiation Oncology. This is an instructional video on target delineation for the International IMRT protocol. We're looking at a CT simulation scan for a patient with stage 2B cervical cancer. The first thing we'll go over is the simulation process for this patient. This patient underwent PET CT simulation with 2.5 millimeters slice thickness in the supine position. The scan was obtained from the T12 vertebral body extending to 5 centimeters below the ischial tuberosities. The patient was immobilized using a custom immobilization device. IV contrast was administered to this patient. Oral contrast was not. That's optional for this protocol. In this case, the patient had fiducials implanted in the cervical mass. That's optional. And vaginal marker or cervical marker is also optional to assist with target delineation. Those were not used in this patient. This patient was simulated in the empty bladder state, or attempted to be simulated in the empty bladder state to ensure maximal reproducibility during treatment and to facilitate PET imaging. The isocenter in this case was placed 1.5 centimeters caudal to the inferior border of the SI joint. We'll proceed with describing the target delineation process. The first thing we'll do is outline the GTV, and for this we'll use the PET portion of the scan as well as an MRI that was obtained to assist with target delineation. First we'll blend the PET scan here. So here we're at the level of the L5-S1 interspace. Now we're going to proceed down. Here we see the uterus come into view, and inferior to that we should start to see the GTV, which has been outlined already, starting here. The patient has a very large cervical mass extending into the proximal vagina, and the PET scan is used as a guide here to, here you can see abnormal FDG uptake in the mass, and we use this to help assist with target delineation here. The next step is to contour the clinical target volume 1. Actually, we'll look at the MRI as well for GTV delineation. However, the patient was in a different state of bladder and rectal filling. Here you can see a large cervical mass, which is in the vicinity of the gross tumor volume, but the position is slightly altered due to the changes in bladder and rectal filling state. So we use this as a guide for tumor delineation, but the GTV is delineated on the CT. Now we'll proceed with delineation of the clinical target volume 1, which is defined as including the GTV plus the uterus. And the remainder of the cervix. So here we see this, the clinical target volume 1 starts here at the upper part of the fundus of the uterus. We've outlined the entire uterus and the cervical mass in continuity, extending down into the proximal vagina. So that demarcates CTV1. CTV2 is defined as the parametrial tissues and vagina. In this case, we'll contour the upper half of the vagina. We'll include the ovaries here and periuterine fat, as well as the paracervical tissue here going inferiorly will include in CTV2 a lateral border around the tumor, and then the proximal vagina in its entirety to this level. This contour can be defined and overlap with CTV1. It won't matter. In this case, it's been the CTV1 has been subtracted out to facilitate visualization. Finally, we'll discuss the nodal volume, which is the most complicated of the three to contour, and we'll start this nodal volume at the level of the L4, L5 interspace. Here, what is important to note is to maintain about a 7 millimeter margin around the vessels. This can be done either with a auto boundary tool or by outlining the vessels and using an expansion, but it would be important to subtract any part of the nodal CTV that extends into the bone or muscle or bow, as here. So as we go down, we'll cover the common iliac nodes. We'll take the CTV out of the bone. We'll contour a nice margin around the vessels, trying to maintain a 7 millimeter margin here. As we get down to the level of the sacrum, we'll begin to take this volume posteriorly to cover the presacral nodes. Here, as the vessels begin to diverge into the external and internal iliac arteries, it's important to maintain a contiguous volume across the entire sacrum and maintain about a 1 centimeter boundary between the anterior border of the vertebral body and the CTV to encompass these nodes here. Once the level of the superior border of the S3 vertebral body is reached, you should begin to start separating these nodal volumes. Here we'll just continue to maintain a 7 millimeter margin around the external and internal iliac vessels. We extend this inferior, and at the level of the femoral head, when this begins to come into view, we'll begin to retract this nodal volume here, and we'll discontinue following the external iliac, which will become the femoral artery and vein, and we'll concentrate on outlining the pelvic nodes with a margin. Once these vessels are no longer in view, we'll discontinue the nodal volume here. So once these volumes have been contoured together, it may be useful to combine these together into a single structure called CTV. You can do this by using Boolean operators here, and then we're ready to define the planning target volume. So in the case of the PTV1, a uniform margin of 15 millimeters should be applied around CTV1. Like so. The PTV2 should consist of a 10 millimeter margin around CTV2, and PTV3 should consist of a 7 millimeter margin around CTV3, like so, and these can be merged together into a common structure. It won't let me do that because it's been planned on, but this is the resulting PTV, which is the union of PTV 1, 2, and 3, which you can see here. So that is how PTV delineation should be conducted for patients with intact cervix cancer on this protocol. We'll do separate videos on normal tissue delineation and target delineation for patients with postoperative cervix cancer, as well as an instructional video on treatment planning and evaluation.